everybody, and welcome. My name's Rebecca Jackson. I'm the PI of the Center for Clinical and Translational Science funded by the NIH CTSA, and I think it's really important to recognize all of you for being here today because, in fact, the CTSA is your CTSA, and we're really excited that you're all here today to, I think, learn a little bit about one of the most exciting new areas in science moving forward across the nation, which is an area of comparative effectiveness research. I'd be remiss, first of all, in starting off without thanking all of the people who did all of the work necessary for this. Valerie DeGroff, I don't know where Valerie's hiding, is the research concierge, and she's back in the back. So anytime you need something, feel free to ask Valerie, because if she doesn't know the answer, she'll go find it for you. But certainly Valerie and her team have put together a program today that I really think has two major goals. The first is, I think, for all of us to kind of get up to speed or to understand what exactly is comparative effectiveness research. Because certainly it's an area that I think there's a lot of controversy what the definition is. It's clearly not comparative efficacy, but it really is understanding how one intervention or one lifestyle choice or one drug or one something really is relative to the others from a patient-centered or a person-centered perspective, as well as a societal perspective. The second goal of this, I think, is to understand how you might be able to take the scientific questions that really make you get up in the morning and get excited about being involved, how you might be able to do that using the resources across the Ohio State University. And that includes not only the resources within the CTSA, and we're going to demonstrate some of those, and there's lots of booths outside that at lunchtime I hope that you'll spend the time to stop and talk to some of the individuals there, as well as look at the posters from our pilot awardees over the last year. But also, I think, thinking about it from the broader, because comparative effectiveness research isn't just within the health science colleges, and I think it's important that all of us at Ohio State, we're a land-grant university, as you know, and we really have a commitment for making the world a better place, and certainly our state a better place for all of us to live in, and I think comparative effectiveness really resonates well with that primary goal. Again, thanks for putting on your galoshes and coming here, and I'm going to turn it over to our moderator for the morning, who's Al Demby, who's going to introduce our first speaker and start our morning off. Thank you, and go Bucks.
Thank you, Becky. Good morning to everyone. Thanks for coming out and braving the snow. We're going to try to make all the talks and presentations today go quickly and smoothly so that we can not get out too late this afternoon. I know that more snow is expected. So I have the pleasure today. Again, my name's Al Demby. I'm director of Ohio State University Center for Health Outcomes Policy and Evaluation Studies, and I'm one of the program directors within the CCTS here, so it's a pleasure to be here today. It's my pleasure really to introduce our first speaker, who I've known for quite a while, at least 15 or 16 years. Mark Kaiser has just arrived here at Ohio State from the University of Washington in Seattle. He is at least our college's, I'm in the College of Public Health, and he's our college's first endowed professor. He's the Stephen F. Labes Professor of Health Services Management and Policy, formerly at the University of Washington. He was the named in 1998 as the Roman Haas Distinguished Professorship in their Department of Health Sciences. He's one of the really distinguished health services researchers and healthcare researchers in the nation. We're very happy to have him with us today. So, Dr. Mark Kaiser.
Well, let me also offer my welcome and thanks for braving the weather. We hope that it won't get too much worse. Al, thanks for those kind remarks. What I'm going to do today to kind of kick things off is talk a little bit about my understanding of CER. I think, frankly, it's a little bit amorphous with lots of gray area, but there are some boundaries, and I think Becky alluded to them. The title of my talk And Lisa's not here yet. I actually got the idea for part of the title from talking to her earlier in the week. Comparative Effectiveness Research, New Opportunities from Old Wine in a New Bottle. And I don't mean that really in a pejorative sense. So, as many of you know, there are important gaps in evidence regarding effectiveness of healthcare research. I guess the question comes up, well, why comparative effectiveness now? We also know there are significant health disparities among population groups, and there's obviously a critical need for better information about healthcare effectiveness. RCTs do provide evidence that's scientifically strong, but I think there's been a growing awareness that they have limited practical utility because of oftentimes their restricted generalizability. So what is CER? This is just a quote from the IOM report that came out in 2009. CER is a generation and synthesis of evidence that compares the benefits and harms of alternative methods to prevent, diagnose, treat, and monitor a clinical condition or to improve the delivery of care. The purpose of CER is to assist consumers, clinicians, purchasers, and policymakers. So that's a long, pretty comprehensive list if you think about it. To make informed decisions that will improve health care at both the individual and population levels. I think the one thing it's safe to say about CER is it's going to cast a very broad net, which I find very exciting. And I'll say some more about that in the next few minutes. Okay, CER is old wine, but, and I think this is what's important, new opportunities. In many ways, CER does represent, as I've said, it's old wine in a new bottle. Researchers, after all, have been studying effectiveness of healthcare for decades, and many of you have in different ways, I'm sure. But CER is focused on producing evidence to enhance decision-making at the clinical management and policy levels, and it will create, and this is what I find exciting, many opportunities for new applied research activity aimed at improving clinical care and supporting better policymaking. Well, what's exciting about CER? Well, first of all, there's a lot of money on the table. Approximately $1 billion has been allocated by Congress as a down payment for developing a national CER program. The unifying theme of CER is improving clinical decision-making and enhancing healthcare policy formulation. So it's an inherently applied endeavor that has some very basic practical goals. CER is broad in scope and includes many different methods and a wide range of health services, all the way from primary prevention to advanced medical treatments. Well, what is CER? An applied, as I've said, research activity conducted in settings aimed at improving clinical decision-making and policy formulation. And it encompasses a broad array of methods, including RCTs, designed to assess clinical effectiveness. And I've highlighted effectiveness contrasted from efficacy, as well as observational studies and meta-analyses. So it really, in terms of its methods, again, intends to cast a very broad net, depending on the evidence base that exists for a particular area. It also includes research intended to evaluate dissemination and translation approaches. So not only is the idea, I think, from CER to generate information, but just as important, if not more important, to take the next step and find better ways of getting that new information into practice and to increase the evidence base for policy. Well, what isn't CER? CER would not include traditional randomized controlled trials designed to assess efficacy under narrowly controlled conditions involving highly selected patient groups. And there I think it's safe to say the science of many RCTs is strong, but their generalizability is often restricted. It would include, though, RCTs aimed at assessing effectiveness of different healthcare services delivered under real-world conditions. So it's not that nobody can do an RCT under the banner of comparative effectiveness research. It's just that what I think is most important is that the goal is to assess effectiveness under real-world conditions. Well, what's the current state of CER? There has been CER going on. It may not be formally viewed as CER, but public and private institutions are currently involved in CER. But the efforts tend to be fragmented. The databases and patient registries also tend to be fragmented. Accessing private databases such as MarketScan and Medicare data can be difficult and costly. CER studies often don't include subgroups and generally focus on therapeutics, not interventions or the delivery system. This is a schematic that I developed from the Coordinating Council report, which came out in June '09. And how they view it, I think, is useful. They've got 4 pipes representing research, human and scientific capital, data infrastructure, and dissemination and translation. And they make the point in this, and then they have cross-cutting themes: priority populations, priority conditions, and types of interventions. So one can either focus on a particular column and cut across these themes, or focus on priority conditions, perhaps, and cut across the columns. And my understanding is that both kinds of work will be funded under the banner of CER. I think an important point to realize in CER, and it comes through loud and clear in the material that's been produced so far, is that an important goal of it is to reduce health disparities. Analyzing health care provided to subgroups, often not included in traditional RCTs, such as women, minorities, and children, will be important, and I think it's fair to say will get particular attention from the funding agencies. Identifying value through CER. There is a need to assess costs and benefits of healthcare, we all know that, to establish their value. And value may be judged from different perspectives: patients, providers, and the payer's perspective. What CER is not intended to do is to identify the least, and there has been some concern about this, at least early on. It's not intended to identify the least costly healthcare service and then promote changes in reimbursement to promote those less costly services. What it is intended to do, I think is fair, is really help us establish an evidence base for what represents value. And I think that is a goal that certainly is worth pursuing and hopefully will be advanced by the CER program. I think another exciting aspect of CER is that it'll open opportunities for collaboration. This is just my short list, but I think it's fair to say that CER collaborative research will oftentimes involve clinicians, clinician researchers, patients and patient stakeholder groups, informatics researchers, health services researchers, healthcare administrators, and community health professionals. So again, I find one of the exciting things about CER is that it really is going to afford new opportunities to do some, I think, very interesting collaborative work. CER will obviously require the development of robust data sources, including patient registries, clinical data networks, electronic data with outcomes information, and there will be funding made available to do this. Clearly, if the goals of CER are to be advanced, there's going to need to be much more robust data sources developed. This is just a very short list of a smattering of priority topics that were generated by the work done earlier in '09 by the Institute of Medicine. These aren't in any order of priority, but what I wanted to do is just give you a flavor for how broad a net CER is really casting, in this case, in terms of its priority topics. Hearing loss treatments for children and adults, comprehensive care coordination programs for children and adults with severe chronic disease. So you can see here, we're talking about system delivery, the kind of research that I have done, system delivery interventions. Disseminate and translate techniques to promote CER. This will be a very important part of the evolving story of CER. Establish prospective registries to conduct CER on treatment strategies for low back pain, very costly, fairly prevalent condition, as many of you know. In school-based interventions, vending machines, for example, physical education to prevent and treat overweight, obesity in children and adolescents. So again, I hope you get the flavor of the breadth of CER. It will include everything from doing research on school-based interventions to prevent obesity to activities designed to improve the dissemination and translation of techniques to promote CER use, to change practice patterns, to system delivery interventions, improving care coordination, and everything in between. So it really is very, very comprehensive. What are the implications of CER topics? Well, CER, I guess as I've said, it's probably worth repeating, will assess a broad array of health-related outcomes for diverse patient populations and subgroups. The interventions analyzed may include medications, procedures, medical and assistive devices and technologies, diagnostic testing, and even behavioral change and delivery system strategies. So this list, if you think about it, pretty much covers a lot of the waterfront, if not all of the waterfront, in terms of health services. It will also allow an opportunity for the development or the use of different study designs, including randomized controlled trials, if they're designed appropriately to really focus on assessing effectiveness in real-world conditions. Retrospective and prospective cohort studies, intervention studies, also the development of longitudinal data sets to do that kind of work. And here, of course, the key issue is eligibility. People become eligible and then they lose their eligibility for programs such as Medicaid. That will raise a number of issues. CER will place heavy reliance on different methods: instrumental variables estimation, risk adjustment, propensity score methods, data management and file construction, choice of statistical techniques. I think it's fair to say that a lot of the data that's going to be accumulated and analyzed under CER is going to be observational in nature, which raises immediately a whole host of questions about the validity of the evidence produced by observational data. So lots of opportunities to push the envelope forward on the methods front. What are some of the key challenges of CER? Again, this is just my very short list. I think a really key challenge will be developing and maintaining robust data sources that include priority populations. It just won't be enough to have a highly detailed data set on a small set of patients coming through a clinic. Data sets that have relevant outcomes and that provide reliable information on covariates and comorbidities. That's often a challenge. And that also offer the opportunity to link with other kinds of databases, such as cancer registries and data on vital statistics. So this whole question of developing and maintaining robust data sources, I think people that are very much in the middle of this realize that that is going to be a key challenge. Another key challenge, though, is going to be the development of trained workforce. I think the government, NIH, HRQ realize that we simply do not have enough trained researchers, clinician researchers at this point, to carry out this ambitious agenda. And so there will be opportunities to enhance the training. I think exciting opportunities, actually. And then lastly on my short list, I think another challenge will be to develop effective approaches to disseminate and translate CER findings to improve decision making. I think at the end of the day, unless decision making on the part of patients, on the part of clinicians, on the part of policymakers is not enhanced by the evidence produced by CER, I think everybody would consider it falling short of its goals. Some key considerations of CER funding. I wouldn't exactly call these criteria, but clearly one of the things that's going to be important is the potential impact of a condition that might be targeted for CER. The prevalence of the condition, burden of the disease, variability in outcomes, etc. A second consideration is the potential to access comparative effectiveness in patient subgroups, minorities, in people, in children, in the elderly. That's going to be very important. Uncertainty regarding management decisions and the variability in practice. In areas where there's more uncertainty, I think it's, other things equal, I think it's fair to say that funders will look more closely at those kinds of proposals. The need to address gaps unlikely to be addressed through other approaches. And then finally, the potential for what you might call multiplicative effect. For example, building a data infrastructure that then lays the foundation for future CER work. So these are just a few, by no means an exhaustive list, of some of the considerations that I think will go into making funding decisions. Now I want to turn in the, I guess, 15 or 20 minutes remaining to give you a hint of some of my past research, which, as I was thinking about this talk, I thought, well, have I actually been doing CER, but I didn't realize it? And I'm not fully sure about that. I think some of the work I've been doing would be broadly considered to be CER. And I want to share that just to, I guess, put some flesh on the bones, as it were, to make this a little more concrete and to show you, at least in my experience, where I think we've had some success out in Washington and where, on the other hand, we did good science, and I would say ultimately the information generated by that research had very little effect at all. And I think there's some takeaway lessons from that. So what I've been involved in primarily have been a series of intervention studies in the area of workers' compensation and occupational health care, and then doing some work in the area of substance abuse treatment for Medicaid patients. We started what became a large multi-year pilot project called the Managed Care Pilot Intervention that was started out in Washington and funded by the Department of Labor and Industries, which is our state agency that runs the workers' compensation program, in about 1994. And what this did, among other things, is change the reimbursement from fee-for-service, that had been the traditional reimbursement, to capitation for medical costs, but disability payments were left unchanged. I don't know how many of you are familiar at all with the workers' compensation system, but the way it works, if you suffer an occupational injury or illness, you're entitled to medical payments, and if you miss work, you're also entitled to some wage replacement. That's called disability payments. So this particular intervention changed the way that health plans were paid from fee-for-service to capitation, but it left unchanged the disability payments. And the care was really based upon what we called an occupational medicine model. So what was that? And that was really an important part of the system intervention and the system change. It improved care coordination, it emphasized early return to work, provided integrated case management at the clinic level, and it fostered better provider-employer communication around return to work issues. In workers' comp, an important goal is to get the worker recovered from his or her injury and get them to return to work as promptly as possible. Well, I'll fast forward through all the methods and whatnot. This is our main findings that we published in Medical Care back in the mid-90s. And what it shows is I guess the gold bar is the managed care arm, and the purple is the fee-for-service arm. And you can see there was a difference in medical payments. That wasn't too surprising because we figured, after all, we're capitating these health plans. But what really was a surprise to us was this, because what the nature of this payment was not changed. What was changed were things like care coordination, case management. So the delivery of health care was changed in a way that would promote reduced worker disability. And this is the results. And some of this could certainly be self-selection. This wasn't a randomized trial, but all of it is certainly not self-selection. So we finished that project, and I was prepared to just go on to the next project. But what was interesting, an interesting part of the story was the state agency said, you know, we think that you all have come up with some important data here, some important findings, and we want to carry this, we want to build on these findings, we want to build on this project. So Washington is a worker choice state. Employers cannot direct injured workers to any physician, any chiropractor, any dentist. And so we couldn't do managed care, directing patients to selected physician networks. So the Department of Labor and Industries contracted with a group of us at the University of Washington to do a policy study. We did that. And out of that, and again I'll fast forward, came what was to be known as the Occupational Health Services Project that was started around 2001. And the idea here was to develop what we called Center of Occupational Health and Education pilots. These pilots were really to introduce accountability to the delivery of occupational health. And this whole question of improving accountability in our delivery system, as you know, has become an important topic of late. So the Department of Labor and Industries funded it generously. I don't know what the full tab is now, but it's certainly in the millions of dollars. And we had a research team at the UW do the evaluation. These centers, and I'll talk more about them in just a second, recruited on a voluntary basis community physicians. So physicians self-selected themselves into participation. They delivered care in their offices. There was no change there. There was a change in the nature of accountability here, and there was also a change because this entity provided these physicians with critical support to improve care coordination and to do some other things that they otherwise would not have had that we believe are important. So there were two sites, one in Renton, Washington, where one of the big Boeing plants is. They recruited roughly 160 or so physicians. The other was in Spokane. If you do anything in Washington State, you have to do something west of the mountains and east of the mountains, otherwise you get in trouble. So we put the second pilot site in Spokane, and they've recruited well over 400 physicians. So a good number of physicians participated in this. The control group or comparison group for this became all other physicians in the target area that did not participate. We collected a variety of data that, in the interest of time, I'm not going to go through. It included administrative data as well as survey data, both from injured workers and physicians, qualitative data gathered through focus groups. These are our numbers for the intervention group. These are claims. As you can see, a good number of claims were analyzed, and this is the results of this study. So on average, disability days per claim were reduced by about 4 days. Disability costs per claim were reduced by about $350. Medical costs per claim were reduced by about $250. We have a paper now under review reporting the results of this. So what's the current, and what I didn't tell you that's I think an important part of this story is all the work that went in, much of it I did, to work with stakeholder groups to make them understand what we were doing, why we were doing what we were doing, how to interpret the findings. And where that became important is really shown in this slide, because these pilots went on for several years. We accumulated data. I went around to a number of conferences and reported the data, wrote several papers. But we didn't know if this was just going to end as a pilot or if it was actually going to be continued. Well, what the decision was actually to establish this program on a permanent statewide basis. And I think there's really no question that the program, once it's taken statewide, will enhance accountability and improve quality for injured workers. This seems to me to be in a way, a success story of the kind of research that I hope at least can be sponsored through CER, because it really will make ultimately, I think, important changes in the way occupational health care is delivered and the treatment that is given to injured workers. A less happy story is what I'm going to talk about now. We did an evaluation funded by RWJ, the Robert Wood Johnson Foundation, on a drug-free workplace program. I think there was good science, but that doesn't always guarantee translation of findings for practice or policy. So what this was a state law that was passed in 1996 that established on a pilot basis, a 5-year pilot basis with a sunset provision, a program to address workplace drug and alcohol misuse and reduce occupational injuries. So it established this public program through the workers' compensation system. Employers could participate in this on a strictly voluntary basis. If they did, they got a 5% discount in their workers' compensation premiums. And the intervention included a development of a written workplace policy, an employee assistance program, supervisory training, employee education, and drug testing. So we did a 7-year retrospective cohort study. The intervention cohort consisted of 260 companies. The comparison cohort consisted of all other companies. There were roughly 20,000 of them. This is one of our main findings. So what this shows is over the period of 1994 up through 2000, this is on a quarterly basis, and the yellow is the intervention group, the red is the comparison group. And this is the start of the intervention. So you can see these lines track one another very closely. Once the intervention started, these are injuries per 100-person years. These are 4-quarter moving averages. This goes down and stays down. This is a little fluctuation, but basically remains level. So we found for the construction industry an important effect. These are some additional data showing the number of injuries avoided in these 3 sectors: construction, manufacturing, and service, the estimated amount saved, the premium discount that was paid, and the savings to premium discount ratio. So this program had a selective protective effect. That's what I came to call it, for certain injuries. For certain sectors. And we reported the findings in an article published in Health Services Research in 2004. That article was, we were fortunate enough to win be awarded the John M. Eisenberg Article of the Year Award for the best paper published in Health Services Research. So that was sort of the good news. The bad news is the findings had no impact on policy and the law was allowed to sunset. And my question is, what happened? Well, I think what happened was we didn't do as good a job as we should have, perhaps, in translating our findings to the policymakers. And so even though we came out with this nice paper that was published in a good journal, it had no impact whatsoever on the legislature. And there was some politics involved, but the take-home lesson that I had from this experience was that good science is not enough. You have to, if you're really going to change practice patterns, if you're really going to have an effect on policy, you have to do the hard work of getting to the policymakers, of improving approaches for dissemination and translation of findings into physicians to really have an effect on decision making. And if you don't do that, you can have the best science in the world, and at the end of the day, I'm not sure it'll make much of an impact. At least that was my experience out in Washington. Then lastly, I'll just say a couple things about a more recent project I've been involved in that is a screening, brief intervention, and referral to treatment initiative. This was a federally funded initiative sponsored by SAMHSA, I think they put something between $50 and $100 million into it. Very, very well funded. The whole idea here, I don't know how many of you know much about screening and brief interventions. There's been a growing body of evidence to show that screening and brief interventions, certainly in primary care settings, in other settings, is helpful to promote a reduction in risky drinking. In Washington State, the money was used to start screening and brief intervention programs in hospital emergency departments. So the idea was to screen ED patients using the audit for alcohol, the DAS-10 for drugs, and to provide brief interventions if somebody met the minimal threshold for a brief intervention. There was also attention paid to referring patients for brief therapy or substance abuse treatment. So we conducted a study using that involved analysis of about 1,500 patients that were Medicaid patients that were working age disabled patients. They received at least a BI in one of 9 hospitals. They were screened between April 04 and September 06. Using propensity score matching techniques, we constructed a comparison group and then estimated some difference in difference regression models. So I'll fast forward to the findings, but suffice it to say, we were looking at reductions in Medicaid expenditures the year after screening. Okay, so that was our outcome measure. And you can see that on average, there was a reduction of $366. These are per member per month. So these are, you know, that's a substantial amount. Now, this is a high-risk group. It's disabled, Medicaid, working-aged adult patients. Patients treated for an injury, the reduction was larger, but it wasn't statistically significant, on the order of $700. And then patients with a BI only but no substance abuse treatment, it was about $500. So this represents, I think, a solid piece of research. Again, not a randomized controlled trial, but what we found, we wrote up a paper, it was published last month in Medical Care, that the evidence really added to an existing body of evidence showing that screening and brief intervention programs can reduce risky drinking and decrease health expenditures. There's a whole group of people down in North Carolina at RTI that have a contract from SAMHSA to do a macro evaluation. A number of states are involved, so this is ongoing. But I think the good news from this, not based on our study, there was a lot of good work, good science that had been done before. But the good news is that payers are now considering paying for screening and brief interventions. And if you're going to get a service utilized, it's got to be reimbursed. And also, screening and brief interventions may become part of hospital accreditation. The Joint Commission is now considering that. So, some concluding thoughts. CER, I think, will produce a wide range of new opportunities. Exciting opportunities for collaborative research and training aimed at improving clinical decision-making, policy development. Success will depend on a couple of things. One, I think, is fostering effective collaborative relationships among researchers, healthcare institutions, patient stakeholder groups, community organizations. I think Becky alluded to this earlier. Developing robust data sources, and also preparing a well-trained workforce. Thank you. I guess I have time for a few questions.
Thank you for your talk. You made a very interesting comment about collaborations, and I would just like to make a comment that one of those collaborators or one of those disciplines really is research ethics. And I think this opens up a whole new interpretation of those ethical requirements that Ezekiel Emanuel expounded on, not least of which, as you mentioned, value, validity, in the selection of human subjects for participation.
Mm-hmm. Other questions, comments, thoughts?
Thank you. It was a wonderful talk. I have a quick question. is comparing the effectiveness of two different management strategies in a randomized controlled trial. Is that considered comparative effectiveness research?
Yeah, good question. Well, yes, I would, my short answer would be yes. I think what some of the important considerations are, if it's a head-to-head trial comparing two existing, whether one is usual care or standard of care and the other is something other than that, particularly if it is not a randomized controlled trial that is narrowly focused in rather artificial conditions, if it takes place in what you might call under more real-world conditions, sure, I think that would be quite fundable. I'm going to be involved not as an investigator, but as a chair of an advisory group of an NIH-funded randomized controlled trial taking place out in the VA hospital in Seattle, where they're comparing improved coordination of care for alcohol treatment versus the standard of care. And they're calling that a randomized effectiveness trial because it's going to involve trying to randomize patients, but getting care for the intervention arm and the comparison arm under real-world conditions. I think that's what's...
May I follow up with another question?
Sure.
Let's say if you randomize the strategies, and the innovative arm, if the patient is getting better, and if the family or the parents want a from the comparison group to go back to the innovative therapy, how would you deal with this ethically?
Maybe that's a question we should discuss in the hallway. I'm not sure there's a ready answer to that. Other questions or comments? Yeah.
Since this title is at Ohio State University, is this something that the College of Business or School of Business would do as part of their regular kind of thing? This is what business people talk about every day, and that we should be working with them.
In terms of, I'm not sure I can get in the connection with the business school.
Cost effectiveness.
Uh-huh.
Different.
That's a good question. I guess I would answer that question a couple different ways. I think that under comparative effectiveness research, the idea is to be inclusive rather than exclusive. So if there's somebody in the business school who is interested in this line of research, I don't see why they wouldn't be welcome. I think more likely people in the business school might be interested in getting involved in research involving, say, different delivery systems where one delivery system represents for-profit healthcare organization or organizations and the other non-for-profit. I mean, that kind of work has been done. I think that is the kind of thing that would have more appeal to them. Typically, they don't do a lot of what you'd think of standard cost-effectiveness research that I know of.
Okay, I think we're going to take one more question here.
Hi, I started January 1st as a professor here, so I'm, very new. But I spent the last 9 years doing health services research in the VA, and I was wondering if you could talk a little bit about how this you see, I know it's just your opinion, you see this relating to like their service-directed projects line or their quality enhancement research initiatives type of way of defining applied research, translational research. Do you think this is the same, different? What's your perspective on that?
Well, that's a good question. I'm not that familiar with what you just mentioned in terms of some of the work that the VA is involved in. I know they're involved in a lot of different activities aimed at improving the care that's delivered through that system. But I would say really many kinds of research activities would qualify for different kinds of patient groups, including at the VA, if they incorporate some of these basic principles of comparative effectiveness research. That is to say, they really do have an applied focus. They're undertaken in a real world setting. The idea is to make comparisons, head-to-head comparisons of different treatment strategies or different interventions, which could include, oftentimes does include usual care. So my sense, frankly, and I'm not passing myself off as an expert at all, is that, again, I think the intent is to be inclusive, and if somebody can develop a proposal that really is consistent with the principles of CER, I think that the funding agencies, NIH, HRQ, would take a serious look at it. There's not, I think there's a lot of grayness to comparative effectiveness research. I think it's not something that you can say this definitely is, this definitely isn't. Clearly, there would be research activities that would be more consistent with what I would consider the principles of CER, but that's not to say some other study would not be entertained. So, I guess we're out of time.
Yes, well, I want to thank you very much, and I think that was a good introduction and overview for comparative effectiveness research. We'll have additional opportunities to have questions on this and hear more about this throughout the course of the day. But again, let's all thank Dr. Mark Kaiser very much. Extremely appreciative. Many of you may know of Dr. Simpson. She has been very active at the national level with the Institute of Medicine, with national efforts to sort of formulate a comparative effectiveness agenda. Dr. Simpson is currently director of the Child Policy Research Center at Cincinnati Children's Hospital Medical Center. She's professor of the Division of Health, professor in the Division of Health Policy and Clinical Effectiveness in the Department of Pediatrics at the University of Cincinnati. She's a pediatrician by training, and again, I think we're very fortunate to have you with us here today. Dr. Simpson's talk will take us up to a few minutes before noon. We'll have some question and answers session right before noon, and then we'll take a break at noon for lunch. So this session will take us up to the lunch period. So without further ado, Dr. Simpson.
Thank you, Al. Good morning, everyone. And it is indeed a pleasure to have made it here. It's kind of ugly out there, so. It was not too bad this morning in Cincinnati. I know that Tom Kaiser already spoke, and he and I had a chance to coordinate our remarks a little bit, so hopefully they're complementary. As Al mentioned, I've been involved with the Institute of Medicine and have colleagues working very closely in HHS on CER, so I'm drawing from a lot of different pieces to try to give you a sense of really the opportunities for CTSA investigators for CER and where this is going. What I'm going to do is just briefly tell you a little bit about the CPRC in case any of you, we are already through the CTSA collaborating on one initiative in the Community Engagement Corps, and I think there are lots of opportunities for collaboration between OSU and Cincinnati. So I'm going to tell you a little bit about our center, then talk a little bit about sort of why CER, why now, and I don't know if Tom used the phrase old wine in new bottles, but he had said it to me, and I had to shake my head. I've been, part of my background is I'm the former deputy director of the Agency for Healthcare Research and Quality, which is the lead federal agency for health services research, and the challenge often there when the agency was almost defunded by the 1994 Congress. Actually, it was interesting, the person who zeroed out the agency's budget is running for governor in Ohio. Tom Kasich, whatever his first name is, Representative Kasich at the time. John Kasich, that's right. So I saw the agency through decreases and then increases with Joan Eisenberg. And I really do think that there's a dimension of this, which is the old wines, but I actually think there's some very important differences here that we need to keep an eye on, and I'm going to try to touch on those. I'm going to talk about the definitions and scope. You might have seen some of that. I'm going to then touch on, obviously, what we're all interested in as academics is the funding opportunities, what's out there now, what's likely to be out there in the future. And then because I happen to be the co-chair of the Key Function Committee for the CTSA Consortium, I'm going to touch on some of the goals of that committee. Now, are any of you involved with the Key Function Committee on CER? Okay, so you won't have seen these slides before, so hopefully they can help, again, really sort of bring this more closely home. How many of you are bench scientists? Okay, how many of you are clinical researchers? The bulk. How many of you work more on the community engagement side? And how many of you are currently funded CTSA investigators? Just a few. Okay, that helps to kind of understand the audience a little bit. I also want to acknowledge some key folks who I'm drawing from their work here. Sean Tunis was on the committee, the IOM committee with me. He's a former head of the Medicare quality or one of the agencies within Medicare, a very knowledgeable guy about comparative effectiveness research. Washington loves acronyms, so the FCCCER is the Federal Coordinating Committee for Comparative Effectiveness Research, and Patrick Conway is a faculty member at Cincinnati Children's who's been on loan to HHS for the last 2.5 years. And then I mentioned the Key Function Committee. So in terms of our center, the Child Policy Research Center develops, translates, and communicates evidence to measurably improve child health and well-being and the quality of health care for children. And so the important point for any of you who work in the field of child health, is that while we focus on the performance of the healthcare system and the more classic health services research, we also focus on the broader definition of child health and well-being. And we partner very much with colleagues that you may have here in Columbus, policymakers here within Medicaid and Department of Health, as well as nationally. And the type of work that we do, you'll hear some of these methodologies in CER, is very much using large data sets, whether generated by survey, primary data collection, or by administrative data. For adults, that's usually Medicare. For pediatrics, it's Medicaid, and do a lot of research on healthcare patterns. And then try to communicate those out. Our particular topic areas in the population child health area are birth outcomes, obesity, and injury. And our portfolio in the first two is greater than the injury portfolio. That is just growing. So moving from our center, why are we talking about CER? Why was there all this investment in CER? Well, the reality is the interest in comparative information is not new. Decision makers and in the healthcare systems have been asking for what works better. If any of you have experienced a serious health challenge, I'm a breast cancer survivor coming on to my 10th year, you're faced with clinical decisions about what's the best treatment for me in my situation. And so this is not new, the demand for option A versus option B and the relative effectiveness of them. But it's often in the policy arena framed in terms of payment and coverage decisions. In other words, should we pay for A versus B if one of them is much more expensive than the other, and those questions. And it also, Gail Walensky, in one of her articles in Health Affairs, said that the interest in this kind of comparative information really grows whenever there's interest in competition, because then, who's going to win in the healthcare marketplace? And so it's generated a lot of what I call in-house capabilities among health plans in this country to do their own comparative effectiveness reviews so they can make in-house decisions about their benefits, their medical necessity, and their coverage for their covered employees. And at one point in my career, I was the maternal and child health director for the state of Hawaii, and I used to say that, as much as I could inform public policy there, at best, the population, I'm trying to remember, moms and kids in Hawaii was somewhere under 1 million. Or that's the total state population. And then you think about United Healthcare or WellPoint, and they're making policy decisions about what to pay for and what to cover that covers hundreds of millions of covered lives. So the impact of private policy decisions is really quite significant on what ultimately gets received by patients on the ground. And here the U.S. is somewhat behind other countries because comparative effectiveness funding and lead agencies that are well supported are much more well established in the UK and Canada, Australia, and Germany. Not surprisingly, they have national health insurance schemes, and those kinds of coverage, treatment decision, availability of coverage and payment is made more centrally. And then the final point is a lot of the emphasis to date on comparative information has focused on pharmaceuticals. I mean, the FDA and a lot of the research has been, again, drug A versus drug B, or device or biologic A versus B, and what's the relative effectiveness of them. But I think we're seeing a real growth in that question about A versus B for all kinds of interventions, not just pharmaceuticals. The scary thing is that people are expecting a lot from CER, and this is from Peter Orzag, the head of the Office of Management and Budget, his testimony a couple years ago, that better information about the cost benefits and benefits of different treatment options combined with new incentive structures is essential to putting the country on a sounder long-term fiscal path. So there's a belief, and this you'll also see reflected later in some of my slides, on the emphasis now on behavioral economics. How many of you have heard of that term? Okay, so this is like the latest policy darling strategy, I think, that's my own opinion, in Washington, that clearly we all know that getting evidence out there doesn't change systems. We have to better align as a policy lever the financial incentives, whether those are at the system level, the hospital payment level, but also at the individual doctor and patient level. And that's the sort of growing focus on behavioral economics. There's a good kind of commentary on it in the New England Journal just within the last, I think, 2 years, so you may want to look at that. Now, this is probably a familiar slide for you. It's from Sung's, when the Clinical Research Roundtable, I should have the site down there, came out back in, I think it was 2003, with this identification of the terminology. We're well familiar with the T1, T2 blocks. And obviously, a lot of the research that goes on in places like OSU or CCHMC or University of Cincinnati is very much focused on this first translational block. But where we're talking about now is really the second T2 block where CER comes in. There's also been an article written in JAMA that I'm not going to go into, but where the T2 block is actually sort of exploded into T2 and T3. And now I understand Joel Savat, who's one of our co-PIs at UC for our CTSA, talks about, I think some people have described T's up to 20. So I don't know what those are, but kind of you can at least think we're at the T2 level. And I think this is Sean Tunis used this at a presentation in Cincinnati about a year ago, and the reason I mention it is I think you'll see the next couple slides that it's very helpful to talk about this, I think, with our basic science colleagues. So how do you reconcile this paradox of more than 18,000 randomized trials are published every year, yet when the evidence is summarized and synthesized for decision makers, often we find that the statement is made, available evidence is either limited to answer the question or of poor quality. And so the decision makers, and by decision makers here we're talking about not just doctors and patients, but also hospital managers and system managers and plans, that the patients in the trials are often highly selective. So they have very little to do with the patients you're facing in your practice or in your health plan. That the research settings are not typical of the community. That the comparisons are either missing completely or just not correct. And that the outcomes are physiologic or surrogate and don't address functional outcomes. And then the results often come out years after the decision had to be made. So those are some of the gaps that are seen by decision makers. And another gap, which we're hearing more and more cry from Washington from, particularly with the more than doubling of the NIH budget that we've seen over the last 15 years, is decision makers, i.e. people investing in the research enterprise, are saying, I can't influence what gets done. What are the results? I need answers to my questions. And so this is Sean's model of what he calls the molecular basis of uncertainty, and I think it's quite fun, so I'm going to walk you through this. Most of research starts with intellectual curiosity that then informs the clinical research enterprise where many of us have lived. And this is what he describes as low affinity receptors for decision makers. In other words, this community doesn't really talk to the people who use their results or need their results. What does get generated out of that enterprise is published evidence. And unfortunately, there's this big block of slow diffusion into this intracellular space over here, which is where decision makers live. And so there's very slow transport. Sometimes there's active transport, and these are these systematic reviews, technology assessments, where that evidence is made more digestible for people to use it. And then it comes through here to these decision makers who themselves have a very low affinity receptors for evidence, very low tolerance for the results that we produce. And so what happens is they say, what you did really doesn't help me. There's a gap in the evidence you've produced. You have not answered my question. Or if you did, you answered it too late for my purposes. And this doesn't get transported back out to where the intellectual questions start happening. So you end up with this sort of circular defective transport, and all of these questions and needs within the intracellular space never kind of connecting to where the science gets developed. So I think it's important to understand that what CER is trying to do is to really make this membrane much more permeable in both ways, so that what gets done over there is informed by what is needed here, and then that what gets produced actually gets applied. And so we're trying to change these receptors into high affinity receptors on both sides. Now, Tom, did you cover the ERA details of all the money?
No.
Okay, so in a quick summary, the Stimulus Act allocated $1.1 billion for CER to be spent in the 2 years. Now, the good news, as opposed to some of the other job creation investments, the spend has to start within the 2 years. It doesn't have to be completed within the 2 years. And so the $1.1 billion, $400 million was given to the Office of the Secretary, $400 million to NIH, and $300 million to ARC. And NIH solicited their money much earlier. We started seeing the RFPs last summer for those, for that spend. We're still seeing some. ARC started developing theirs, and the RFPs came out in the fall. And the Office of the Secretary's money has just been kind of coming out since November in terms of the FOAs with deadlines. If any of you responded, it was a fun Christmas, but a lot of them were 1 month deadlines between December 20th and January 20th. That's a whole other story. And then it established the Federal Coordinating Council in legislation. This existed sort of informally at HHS. It requires a report, and it required an IOM committee as well. And a point I'm going to emphasize many times is that one of the dimensions of comparative effectiveness research is this clamor for transparency on what you're doing, why you're doing it, and engagement by consumers and stakeholders at many steps along the process. I think to maybe keep us honest and on track about what we're doing. Now, the definitions and scope, the committee that was established was unheard of for the IOM, that normally, if you're familiar with how the IOM works, takes about 2 years to deliberate and go through this very formal but very confidential process of deliberations until the final report comes out. This was a dramatic departure for the IOM. First of all, we had 19 weeks to put this report together. And second, it was driven by a tremendous amount of public input that was required. And the charge was to develop, to obtain national input and come up with a list of 100 actions for the priorities, and also what else needed to be done to create this sort of national enterprise for CER research, because the belief is that this 2-year investment of $1.1 billion is not the end. There is going to be continued investments in CER, and so we need to build a workforce and an infrastructure to actually produce results much more quickly. Tom, did you cover the definitions? Okay. So, and this one too, the FCC? Okay, so as opposed, they're very similar definitions, but it's interesting, as usual, Washington had to develop 2 different definitions. But the important one here that I want to, the important aspects of this that I want to emphasize is, again, the theme on real-world settings, not highly selected populations and settings, that it's very much focused on improving health outcomes, and then it identifies the audiences, and they're responding to their expressed needs. And again, audience-driven in terms of priority setting for the research. And then the emphasis on specificity. And this is another big theme with CER, is that this result works, but this treatment works better, A versus B, but for which population subgroup, under what conditions? We're recognizing more and more that the context and the specific match between patients and providers really can influence outcomes quite tremendously. The subpoints of the federal definition were that it's got to, the point I just made, the diverse patient populations and subgroups. It also very specifically said that to include delivery system strategies. So not just what one would think traditionally in terms of clinical interventions of of pharmaceuticals, therapeutics, biologics, diagnostic testing, behavioral change, and the delivery system itself. And that was a heavier emphasis on the federal committee than the IOM, even though in our IOM deliberations we also spoke to that, and you'll see that in some of the priorities I'm going to showcase. The other emphasis in CER is the use of a variety of data sources, and a big part of the $400 million investment that the Office of the Secretary has put out there is emphasizing data infrastructure to build better data. Again, there's the interaction with health IT and electronic health records, and the belief that we're going to really have much more information to drive comparative effectiveness research as a byproduct of clinical care with more integrated electronic health records. That's the vision. The question is, can we deliver? So to some of the defining characteristics is, again, as I've mentioned, directly informing decisions and comparisons. Again, it bears repeating. It really is about, does A work better than B? Not just does A work in real world settings for which patients. It's, is it better than something else? And for which endpoints? Is it better outcomes? Is it lower adverse events? So looking at a range of outcomes and understanding, again, the comparisons. The subgroup emphasis and really matching the methods and data to the decision of interest. So again, understanding who needs this information for what decision and using the methods and data to answer that as well as possible. In terms of the categories of methods, there really is a broad range. And I want to emphasize that, again, experimental studies are very much a part of CER, but they're only one method. And you'll see in the IOM summary of the 100 priorities how many of those studies are actually experimental designs that were recommended. And that the important point that all methods have a role, and again, it's matching the method to the question at hand. So let's go to the funding priorities. I'm going to skip through these slides rather quickly in the interest of time, but just to give you a sense of how we funneled down from a huge amount of input into the specific list of 100. And all of these are available online at the IOM. There was a web-based questionnaire, there were presentations in Washington, and then independent direct correspondence with the committee. And what that generated was over 2,600 recommended priorities from over 1,700 respondents. And then they were screened by us, and we excluded 335 because they were non-responsive. There were some basic science questions about molecular mechanisms that were submitted. Of 1,000 were excluded due to verbatim duplication. And this was, are any of you doing autism-related research? No, okay. Oh, one person. Well, the autism community must have sent out a sort of, here's what you put into the survey, and I think there were 600 with the same survey, the same recommendation that were obviously, volume didn't matter, it was content. So some of the others had done that as well. And we looked at not just the research area, but also the population to be studied, the types of interventions, and the proposed methodology. The intent of the committee was very much to come up with a balanced portfolio, so it wouldn't all end up being responding to a certain type of question, a certain type of method, or a certain population. There were condition level criteria, which are pretty typical. MEPS is a data set that we use to come up with the data for that. These are fairly typical priority setting criteria. Also then, is the topic actually appropriate for CER? In certain instances, we don't even, in many instances, we don't have the efficacy evidence of does treatment A even work? That's not ready for CER. We've got to be able to have already evidence of efficacy before you can start comparing effectiveness between two treatments. So was it, and there were many questions that came in that they were very valid, important research questions, but not for priority in CER. And you can see we went through a voting process that gradually we got ourselves down through series of rounds, down to 200, then down to 145, and then finally ended up after the third round of voting with 100 priority topics. The committee was included representatives from consumer advocates. We had somebody from Consumer Reports on there, the Alzheimer's Association, breast cancer advocates, I think at least four consumer sort of voices, health plan representatives, and then expert researchers were included. I have to mention that I was the only pediatrician on the panel, and there were 16 internists. So it was hard being the sole pediatric expert. So here is the final list of the 100 priorities represented by whether they were a primary research area was in one of these topics or in the secondary research area. And I'm just going to focus on the top 5 here. You see that the actual number of votes were gotten, the biggest vote getter was on health delivery questions. And again, I'll give you some examples in a second to make that more clear. But I think that initially people thought there was going to be too much of an emphasis on this, again, drug A versus drug B, which one works better. And yet the field and the committee, similar to the federal coordinating committee, thought that an emphasis on health delivery was really important. Disparities, disability, cardiovascular, and geriatrics. So those were the top 5. Again, all of these results are on the website. I want to also just look quickly at which study populations had how many topics. You'll see adults had the largest number, that includes the elderly. The general population, women 27, children and adolescents only 20, but many of the general questions also are of relevance to children and adolescents. So you can see that there was a range of populations, and here are the types of interventions that are being recommended for study. So systems of care, various aspects around medical home and home care and different settings, those kinds of things. Pharmacological treatment, still very, very important, but not uniquely so. Standards of care, behavioral treatment, prevention, and so on. So again, a range of interventions being recommended for study. And here's the slide I alluded to earlier in terms of the type of methodology that the priority recommended. And you'll see that RCTs, or randomized trials, are still the most prevalent methodology for study in the IOM's 100 list. And I think we were very sanguine in our discussion and debate around the potential, but also the pitfalls of secondary administrative data sets and observational studies. Are any of you women's health researchers? I was at ARC when we lived through the women's health study results on hormone replacement therapy. I was there on the panel with the press and all this because of our U.S. Preventive Services Task Force. So I think it's a very sobering reminder of the limits of observational studies and observational data. But still a big priority around database research and then the systematic reviews. Here are some of the examples from pediatrics that I pulled out just because I do child health. But these include comparing the effectiveness of different treatments for hearing loss. And you'll see that they emphasize specific subgroups again. The effectiveness of comprehensive care coordination programs, as I mentioned earlier, medical home, et cetera, for children and adults with severe chronic disease, especially in populations with known disparities. Comparing strategies for reducing healthcare-associated infections. A lot of money being earmarked for HAI right now by the feds. School-based interventions, including meal programs, vending machines, for treating overweight, preventing and treating overweight and obesity in children and adolescents. And here, I had an interesting conversation with one of my colleagues at one point about school-based intervention and endpoints. And one of the studies I think that had been nominated included as one of the endpoints educational performance. And the reaction from this internist, brilliant internist, was, well, that's not a health outcome. And I had to explain that in pediatrics for children, the ability to function at school is the same as functional status in adults in terms of a health outcome, and it's a core one that we measure and we look to. And so really understanding that there are different ways of thinking about function and outcomes in different populations was critical, and this did make it in. So those are just some specific examples. In addition, the committee came up with a set of 10 recommendations. I'm only highlighting a couple of them. And can you give me a 15-minute check? I can't see a clock anywhere in this room. Yeah, well, I've got lots more. That's why I want. So I want to, again, go through the ones I chose, but that, again, the emphasis on prioritization. It's not just a one-time thing that the feds will just do this one time, but they really, the IOM felt that this needed to be continually updated by the needs of the consumers of the research. The other one was that, as I mentioned earlier, the fully involving consumers, patients, and caregivers in the key aspects, because this affects how we think about the work that we do as researchers, not just involving them in priority setting, but in research proposal development, peer review and dissemination. And so I remember when I was at ARC, that was the time the DoD got around the breast cancer community got around the caps on discretionary spending and got a $200 million earmark put into the DoD defense budget, which is not, a totally different pool to support breast cancer research. It's now up to, I don't know, $1 billion or some very large amount. And they have been involving consumers in peer review panels, scientific review panels, for over a decade now. That is not typical for the NIH-funded work. But there's a big demand for that kind of voice in the decision-making on what gets funded. Other parts of that recommendation is very much about developing strategies, and this is where CTSAs and the Community Engagement Corps can really help with that in terms of how do you do this effectively. It's very hard to involve consumers in a very meaningful way in setting priorities and the research process, and our colleagues in CBPR are really a wonderful resource for doing that more effectively. And then again, participation in CER to really focus on health disparities and special population groups. The recommendation number 7 was about focus on methods. This is an area where there's, I think, a tremendous opportunity, and I hope we see more funding announcements that are focused on methodologic work, because I think there's a real need for some advances in methodologies to better understand how to use the observational data. The 8th recommendation was to develop these data networks, and you'll see this in the HHS funding priorities I'm going to mention, and developing these incentives for cooperation and maintaining data quality. I don't know if you saw the latest FOA from the NIH on these research meetings to promote interdisciplinary research. And it's 2 years of funding just to get people to talk to each other. It's not much funding, but it's very much reach across disciplinary areas, life sciences, planning, spatial analyses, et cetera, reach outside our silos to really do more collaborative work. And then an emphasis on workforce development. And here again, HHS has also embraced that. I don't know, did OSU apply for any of the CER training grants yet? There was a K-12 that was just closed on January 20th. There's a KM1 out. I don't know. There are others. So there's quite a bit of emphasis on training the workforce for CER as well. And then finally, the emphasis on dissemination. So promote rapid adoption of the findings, dissemination, and out again to all the audiences I mentioned earlier. Turning from the IOM, the FCC report, I'm not going to do that much on it, but just to emphasize, this is the framework that they use, that they wanted to look at research, the human and scientific capital, the data infrastructure, and the dissemination and translation. And overlaid with that is priority populations, conditions, and types of interventions to really try to make sure that they're moving all of those agendas forward. And they use prioritization criteria that are quite similar to the IOM, the impact, the diverse populations, those conditions, and this is important, where there's uncertainty and variability. And in adults, there's a lot of national variation studies because of the availability of national Medicare data. In pediatrics or the non-elderly population, it's very hard to do that kind of work unless you have access to private health plan administrative data. To find where that variability is and then do prospective interventions studies. But clearly there are lots of, several states have moved ahead with actually developing all payer, all claims. And this is one of the initiatives out of Mark McClellan's group, the Engelberger Center for Quality at Brookings, is really to try to move this agenda forward and develop, to sort of overcome that limitation if we don't have Medicare-like data on the non-Medicare population, and to try to move that ahead, and that'll be really important. And then this emphasis on data networks, patient registries, and again here, a lot of the funding that's come out since that really emphasizes from the $400 million that the Secretary had, data infrastructure investments and dissemination and translation investments, as opposed to the NIH and ARC funding, which is more sort of in these two buckets here. And in terms of some recent initiative announcements, these are the ones that are current now. But you see that this one's scalable distributed research networks. This one is enhanced registries, so for any existing registry, how to make it better. research, this is the new KM1 that's due, let me see, March 25th for comparative effectiveness research mentored career development. This one gets to the dissemination and use of CER findings, and these get at what I was talking about earlier, the behavioral economics. I love I've never seen the word nudging in an FOA before. But for nudging, the implementation of CER. And again, you see those are clinical trials as well there. So to end the last 5 minutes on what is the Key Function Committee doing through the CTSA Consortium, under the consortium strategic goal 4, which is to enhance the health of our communities in the nation, goal 4B is to promote the translation of clinical and translational research into practice and policy via the consortium's contributions to CER. So through the strategic goal committee and the consortium, you see that there's this recognition that CER needs to be part of CTSA portfolios, and that's both a strategic and important direction, but it's also pragmatic. There's money to be had there, and the CTSAs need money. So, and CTSA investigators, you've probably seen this slide as well that's used to describe the various CTSA components. I included it just to emphasize that, again, the input that's needed for CER from organizations on the left is, I think, a critical component. And since we work a lot in our center on policy research, really the methods of CBPR are quite parallel or analogous to the methods that you need to use with policymakers and health plan decision makers and others. It's about engaging the users of the information in figuring out the question, designing the study, refining it over time, et cetera. So here are, and Harry Selker, and there's a white paper coming out from the CER Key Function Committee. It's accepted, I think, in the Translational Research Journal. It's going to be coming out soon. These are some of the points that they pull out in that paper about what could CTSA consortium resources do to advance CER. Well, obviously building our infrastructure and study design and methods expertise, developing formal programs in education, training, and career development, which is a core piece of all CTSAs. Programs in community engagement, again, a core piece. The informatics, another core. And then a mandate to link different disciplines and to link and coordinate with other CTSAs. And again, this ability of the CTSAs to bring maybe unlikely bedfellows together to really do this kind of work is important. Now, some of the activities of the committee is, it was first, they completed a capacity and needs assessment and related resources across the CTSA, and then they wrote this white paper that I mentioned that's going to be coming out. If anybody's interested in a copy, I have a copy of the white paper. If you don't, you can get it from the CTSA Consortium as well. Also, there's been the development of a CER methods development agenda. There's actually going to be a meeting in May in Washington on this that's moving ahead, facilitating links through the KFC among various institutes and centers at the NIH, and that's proceeding. And also understanding the needs of the CER workforce and the CTSA roles. And so there's a draft report being developed. I have not seen it, even though that says 1209, but I expect we'll see that soon. The white paper makes a series of 6 recommendations, and I'll end after that. The first one is that the CTSA Consortium should organize and support trials, infrastructure, capacities to respond to the needs of CER, especially the ability to link these capacities across institutions to support multi-site. And this is while this is important for all populations, this is especially important for pediatrics, where many of the conditions are so low prevalence that to do any kind of robust and adequately powered study, we really have to do a multi-site study. And so, again, for those of you interested in child health research in collaboration with Cincinnati Children's, I have several colleagues who are working with multi-site studies. The second one is the CTSA Consortium should support the education, training, and career development of CER by funding these various mechanisms. And again, this was a big concern of our IOM committee, that we actually really have the workforce available to do this. And we've applied for one of the K-12s to do this. I don't know, did OSU apply for a, no, Al, I asked you, it doesn't seem like it. I don't know if the Cleveland CTSA did. The third one is to further enhance the community engagement component. And by now you should be getting a sense of these recommendations are very much intended to align with the cores within the CTSA framework and structure itself. And again, we see the opportunity for making the work of CER very much relevant to communities and to the disparities agenda. The fourth one is around new research methods, evidence synthesis, and evidence translation. The fifth one is around the informatics and EHR infrastructure that we're going to need, and these data warehouses that various institutions, I'm assuming OSU also has one. Children's has invested in I2B2 as one of our data warehousing infrastructure strategies. And then finally, developing a network for CER that links to agencies and entities outside the CTSAs. So again, that it makes it easier for CTSA investigators interested in doing CER to leverage other disciplines and other investigators and other centers. And then the paper goes on to map these key objectives against what recommendations are in the white paper for the CTSA, the IOM report, and the federal committee report. And you can see then that it highlights how it's linked to each of the core CTSA components. And as I said, that's the key intent, is really to make this transparent and more accessible to investigators who maybe have not thought about CER in the past. The short-term next steps for the work group is to complete the capacity. There's a short survey that's either gone out or just about to go out on needs assessment. The white paper is being published. The methods is going to be completed. That's a little bit later, but and then the links and networking throughout, and then try to frame the CER workforce needs. And as I mentioned, I haven't seen that one yet. So with that, I want to stop and see if there's any time for questions.
Well, thank you. There's certainly some time for questions. And who would like to start? Let me start with one, and then we'll build up from there. The 100 priority list that came out, how much room is there in the RFAs that are being developed for investigator-initiated ideas that are outside of the priorities? Or is the expectation is that you know, it would be silly to put in a submission for a comparative effectiveness project that's not one of the top 100 priorities?
Thanks for asking that, because I am in many of the FOAs that have come out so far, there is not only the reference to the IOM priorities, but also to priorities that are that were established by the Medicare Modernization Act of 2003, or as people call it, the MMA, which established the Effective Healthcare Program at ARC. And they went through a public process back in 03-04 to develop a set of priority areas. So there's a different list of priority areas and priority conditions that's there. And many of the FOAs say IOM or this, or the priorities in the Federal Coordinating Committee. My sense is that as I review those lists, there's a lot of opportunity there. It's broader rather than limited. But again, I come at it from somebody who's been working kind of in this space in the past. So I think it's definitely broader than the IOM report.
You mentioned that comparative research would only include studies where efficacy is already given. My feeling is that many interventions are not very efficacious at all. So are those excluded, or?
Yeah, it's a great point. Thank you for raising that. I think the field hasn't figured that one out yet, because there's so much, and this is very true in pediatrics, you know, we have much less efficacy evidence for what we do in pediatric practice today than we do for adults. That's been well documented and assessed. I mean, the old adage that 80% of the drugs used in children have never been tested in children. I mean, that's why we have the Better Pharmaceutical for Children's Act and various other legislation to try to promote more studies by the drug companies in children. I think we're going to see how stringent, and again, that's not a criterion in any of the FOAs. That was a sort of a theme and feeling that the field has, that, you know, that's not the highest priority for CER investment. If you don't even know if it works, you should start with efficacy and then go on to effectiveness. But I think there's some gray around the edges for that. And I guess I'm going to wait to see what gets funded out of this first $1.1 billion and how NIH particularly interprets that. I think the ARC investment and the HHS investment is probably going to hew to that criterion more than the NIH investment, but that's just my personal opinion.
Do you have any information about what the plans are for building up clinical trial infrastructure? What other groups are doing to do that, to start that out?
I don't have much. What I can tell you is that there have been a couple of meetings specifically to talk about that infrastructure and what it needs. I'm only really aware of when that conversation touches pediatrics more specifically. For example, Cincinnati Children's has a CERT, which is a Center for Education and Research in Therapeutics, which comes out of ARC. There are 14 of them. We have the only one focused in pediatrics. The others are adult population. And certainly because of that relationship with FDA and with ARC and NIH, there's some conversations going on within that community of centers around what that means and how that might be developed. I'm happy to connect you with some folks who know more about that than I do.
Lisa, I'm curious about your views. I mean, you know, when you think of CER, it's breathtaking in its ambitiousness. At the end of the day, we'll see. I think we're all hopeful. But for me, at this point, one of the disconnects is the translation of information generated by CER to policy and coverage decisions. Do you have any, and I know that that's been a political sensitivity because there was concern that, you know, we'll at the end of the day, it'll just be used as a cost containment, sort of a side door into cost containment. Do you have any, on the other hand, my, I don't know, experience from the work I've done is that physicians actually are as responsive, if not more responsive, to non-financial incentives and financial incentives because they're so completely overwhelmed and burdened by the paperwork that they labor under. That, do you have any views on how this information might be used creatively by payers to start shaping, either through non-financial or financial incentives, to start shaping practice patterns in a way that would be consistent with the information that might be generated out of all this work?
Sure, great question. You know, I've been at this trying to improve practice for kids for a while, and I am very much sobered by how hard it is to change behavior in our healthcare system. It is incredibly difficult. And this is among, you know, it's not like any doctor or nurse goes to work that morning and says, I want to deliver bad care and I want to make medical errors. Of course not. So I think that there's going to remain a lot of emphasis on the payment structure because truly it does interfere with the ability to do the right thing. Not so much that you're going to somehow be a better person when you get paid differently, but it's going to try to align the payment with what is the right thing and make that easier. I think the other big learning I've had over the last decade is that putting all the incentives aside, if you don't create training, knowledge, and capacity to improve and change, you're setting physicians and practices up for failure. And so the focus on actually improvement infrastructure. You know, you can't just take a bunch of docs and say, here's your outcomes and here's how they should be and go, change, and we'll pay you to be when you're better. You actually, there is a method to this. There's a whole improvement science that's emerging and growing in terms of how you actually use data and use results to move practice in the right direction. So I think we have to have a lot more innovation around how to do improvement faster, cheaper, better, because I think the evidence around the improvement collaboratives and all that, while sometimes it's promising, sometimes it's really not very effective either. So I think that's where we can see some innovation coming out of the CER investment as well. And then the third one I would mention, again, flavored by or colored by my years of working at this, but also as a patient and a mother of 8-year-old twins, is I don't think we've harnessed at all the power of patients to change care and to demand different things. I mean, again, an example in pediatrics of, you know, when Parent Magazine started doing lots of articles about, you know, antibiotics are not that great for your kid's otitis. I mean, I remember I was on the NCQA panel for one of the HEDISes way back in the late 90s, and when I said, you know, the Europeans don't treat with antibiotics, they were like, oh my God, no, our measure's got to be appropriate use of antibiotics. I mean, then parents really started to help move that, as well as the public health agenda about, you know, microbial resistance. So I'd like to see parent and consumer see innovation around how you do that well. I don't think we've done it well.
One more quick question, and then we're going to take a lunch break here. Dr. Weisenberg.
First of all, thank you very much. This was a terrific overview. But secondly, a big bolus of money obviously has been put into this through ERA funding. What are the prospects for continued funding of this after ERA goes away? $64 million question. And will health reform pass? You know, I think it's literally very close to the will health reform pass. And if it doesn't, what does Congress do to save face? I mean, I lived through the Clinton plan. I was working at HHS then. And what came out of the Clinton plan when it failed? Does anybody know in this audience? One of the congressional successes was the passage of the state child health insurance program. Congress had to do something that was non-controversial that they could get passed, that was a major win, so they went back to their districts. They could say they did something to improve health. It was for kids, and it was better, and it was the single largest investment in public health and public insurance in children since Medicaid, so it was very important. So while there's all the talk now about we're still going to get health care, the question is, what can they actually get, and what's non-controversial enough? And you know, one of the things that's probably in the non-controversial pot is quality and a focus on more measurement and more investments in quality and infrastructure. That probably everybody agrees on that. I would ask, to what extent is a continued investment in CER, you know, a less controversial provision that we continue to build the evidence to make the system improve itself, even if we don't get healthcare reform? So I think that's just sort of my take on the big picture politics. At the same time, there's the more bureaucratic internal politics that I lived through at HHS, where I don't think NIH, AHRQ, or HHS anywhere wants to lose this from their baseline budget. They've got $1 billion in their budget. They're going to put it forward, is my guess, when that money expires in 2 years from the ERA, as part of their budget request. It's just baseline. It's just continuation. It's a lot easier to keep stuff in there as a continuation than to try to make it a big new initiative. So those are two observations.
Well, I think you'll all agree with me. We've had some really informative and interesting talks this morning on comparative effectiveness research, and I'd like to thank you very much, Dr. Simpson, Dr. Mark Kaiser, Dr. Weisenberger. Very good morning. It's now 12 noon. For those of you who registered, there is lunch waiting for you, I believe, outside. We're going to start up here again at 1 o'clock, I believe, with Pat Gabby's talk at that point. And have good lunch, and we'll see you soon.